Everyone, and welcome today to our first policy briefing presented by the Coalition Connecting for Better Health. I'm Timmy Leslie, and I lead the Connecting for Better Health Coalition. And I'm so pleased to introduce to you our moderator for today's session, Katie Hydorn. Katie is the Executive Director and fearless leader of the Insure the Uninsured project. Katie has been with us from the start, and we really have enjoyed working with Katie and her team as we are really focused on shining a spotlight and also bringing education around the need to accelerate the adoption of health data exchange. Katie, I'm going to hand it off to you.
Thank you so much. It's just been a wonderful partnership, and I've learned so much from all the work that you have done. So I'm really pleased to be here today to contribute a little bit to this conversation. And I'm really excited to give you a little bit of an overview of health information exchange and data exchange, just to level set. And then we have an incredible group of panelists who, even just in the introductions right before this, as we were all gathering, I learned a lot from them. So very excited to have them here with you today. All right, let's get started. So again, welcome to today's session. And this is just a brief intro based on Insure the Uninsured projects, or ITUP, as we call ourselves, based on our HIE 101 fact sheet and a policy forum that we held about 6 months ago. So we pulled together all of those resources for you here. So just before we jump in, just a few key data sharing terms that I want to make sure you have on your radar, as you'll probably hear a lot of this today as we get started. So health information exchange, as you all know, the act of sharing health information to enable, and the technology that enables its action. Then there's health information technology, so the technology that actually facilitates the sharing of that information. You might hear the term interoperability, which we're hearing a lot now. There are some recent federal interoperability rules. It just means that the systems are actually going to work together. So we have to make sure that, one electronic medical record can talk to another one. So making sure that they're interoperable. And then a use case. So you hear us talking about use cases, which really is going to get us into why should we be sharing data. These use cases are unique instances of actually sharing that data to meet a particular healthcare goal. So we'll talk through a few of those as reasons for why data sharing is so important. And then I also wanted to share with you a few different ways that we could share health data. So there's this directed exchange idea where providers send healthcare data to other providers and do care coordination that way. Another type of health data exchange is to query based. So you actually type in, doctors or other providers can search and request patient records. And then you have consumer mediated exchange, where patients themselves actually have access to their own medical records. So I just wanted to distinguish between each of these because they're all different ways to share information, and they, in many cases, use cases, actually talk about sharing data in different ways. So why focus on data sharing? Enables care coordination, promotes population health management, reduces racial and ethnic health disparities. There's a whole reason why, so many reasons why we should actually share all of this data. But as you all know, there are also some major challenges to the sharing of data. Patient privacy concerns. There are conflicting state and federal laws. There's a lot of state and federal regulations around this that don't necessarily align. And then there are also disparate data definitions and use of common data elements. So you really got to get down to the granular level when you're sharing data to make sure that you're sharing it effectively. And that's, as you can imagine, it's incredibly detailed and very difficult to do. So when we look at health information exchange, there are different ways that we can actually share. So we talked about different ways to share data, but then there are also different, going up to kind of the higher level instead of just being at the point of sharing the data. There are ways in which those data sharing, individual data sharing things are organized. You can have a central repository where things are really centralized. You have one privacy consent approach. So we've minimized one of those challenges, but it's really hard to standardize all that data, difficult to scale up, and requires a lot of trust among everyone to actually give all of their data into that centralized place. There's a hybrid, which is really a network of networks and a central hub. And that central hub doesn't necessarily have to hold all the data. You can just pass that data. We have technology that allows us just to pass that data through that central hub. And then there are sort of decentralized systems as well. So we'll make this available to you after the webinar and let you read more into that. But this comes from a colleague of ours who wrote a paper with the California Healthcare Foundation, has some great information behind this table as well. So the real question is, how did we get here? Why do we have all these different policies? So a lot of you are probably familiar with the term HIPAA, and that was from 1996. And this is just a really in my mind, it's a really helpful timeline to say, why are we talking about this again, right? So the last time California really dug into this was really in 2009, when the Health Information Technology for Economic and Clinical Health, fondly referred to as the HITECH Act, and ARA, I think all of you remember ARA from the last recession, when that came into being. So we translated that at the state level into the Medi-Cal Electronic Health Records Incentive Program in 2011. And for the last decade, we've been infusing over $1 billion into federal funds into helping our providers in the state scale up and get into electronic health records. So just to give you a sense, since 2011, only 10 years ago, was when we really started in a big way infusing money into electronic medical records in the Medi-Cal system. In 2019, we invested in CalHOP, which sort of got us to the next level. So we did EMRs, and now we're at Health Information Exchange, making those EMRs talk to each other. And then here we are today, right? So today we had AB 133, which you may remember, it was section 340 of the health trailer bill during this past session, but it set a really aggressive timeline for creating the California Health and Human Services Data Exchange Framework by July 1, 2022. That's only about 9 months from now. So you know, the law also set out some key components for the framework that harken back a little bit to some of the slides I shared earlier. So there will be a single data sharing agreement. There will be a common set of policies and procedures. Remember, that was one of the big challenges that data exchange has. We also want to leverage and advance national standards of information exchange and data content. There are national standards that a lot of health plans and providers use today. So leveraging those, and those are places where entities have already invested. So making sure that we're leveraging those. And then this will also, this framework will govern and require the exchange of health information. So that mandate to exchange information is really critical among healthcare entities and government agencies in California. And this is also really key. The statute sets out what it is. This is technology agnostic. So it means that the framework isn't going to care what kind of technology you're using to hold your information or share that information. It just has to meet certain standards and the common set of the principles. What it is not, so just to be really clear, it's not an IT system, and it's not going to be a single repository of data. So now with this information, go back and take a look at that 2 slides ago. So you can look again at the centralized, hybrid, and decentralized different types of information, and that speaks directly to those models that are in that chart. So where are we now? So as I said, this is a really aggressive timeline. The Cal HHS, the Health and Human Services Agency, has set up a data exchange stakeholder advisory group that some of you may have been listening into. It met 2 days ago. They're meeting about monthly right now. And they have myriad number of subgroups of subcommittees working on all of these nitty-gritty data elements that also need to be included. So that work it essentially has to be concluded so that it aligns with the budget process. So no later than April 1st, 2022 is agency going to have to report out on those on the conversations in the stakeholder advisory group. And then that framework really has to be in place by, as we said, July 1, 2022. So by January 31, all of these entities that are going to be required to share health information exchange, hospitals, physician organizations, medical groups, health plans, et cetera, all of them are going to have to execute this data sharing agreement framework in about a year. It's really, really quick. So there's definitely a big sense of urgency around this. And then there's also, I think, a great desire, as you can see here, to include the county health, public health, and social services departments to participate in this framework and share data. That's also really critical. And so they're encouraged to work with this group as well. And then depending on the size of the system, if you're a big health system or a big hospital or a big health plan, you're going to have to exchange health information in real time. That's very critical, in real time by January 1, 2024. So in only 2 years from now. And then if you're a smaller health system, or as specified, there a long list in the statute, but if you're a smaller health system, if you're a physician practice under 25 physicians, you have until January 31, 2026 to comply with this. So they tried to be sensitive to the idea that it might take a little bit to scale up. We had a couple learnings from other states, both in the work that Timmy mentioned that she's been doing with with the coalition that they're leading. Michigan, I think, is a really good example of this. This just doesn't happen overnight, right? I think we'll let you read this in the slides later, but the idea is that you can scale this up over time. So California is just starting, right? We're at 01. We're engaging stakeholders, developing that statewide vision, addressing legal and HIPAA concerns, all of which is actually really complicated. And then we get to step number 2, right? What we just talked about: implement hospital and provider incentives and begin transmission with hospital level data. So that's all going to start in about a year. And then over time, you get into maturing the system, right? Improving the data quality, increasing the types of data that can be sent to that statewide network. So this gets us into those use cases. What modules do we want to add on so that we're really truly exchanging all of the data, everything from hospital discharge data to coordinating care between primary care and specialty care. Maybe we add in behavioral health data, and then maybe we get into the social determinants of health and start adding in those local public health and social services data that we mentioned earlier. And then, by the time we get to stage 4, this is really built out, and you can solve a lot of problems using this really robust network. So that's where Michigan is in the process. They've made it all the way through this process. Another group that ITEP actually heard from at our policy forum, and these next 2 slides are from their presentation, is the Washington, D.C. Medicaid agency. They went through this. They run a regional exchange with Maryland and I believe Virginia together. And they similarly had, you can see here, I really liked this graphic: process, semantic, syntactic, technical. These are all big words, but it essentially is a similar process to what Michigan went through. You got to get all of your standards together, the process, you got to get your vocabulary and your terminology, everyone aligned. Then you got to figure out what you're actually sending, the content format, and then you got to protect that data. And then we talked about, once you get to that point where you've actually set this up, I loved this graphic because this, to me, these are all the different types of things you can do with health information exchange. For me, I know when I saw this, I went, wow, they're doing this, which means we in California can do this, right? You can send health records and hospital records. You can do care management. You can have a provider directory, and you can do e-referrals and screening. When COVID happened, they had, you can look at our policy forum, we'll make sure that that's available in the chat, but they also talked about how when COVID happened, they were immediately able to leverage their exchange and were able to add on information about COVID cases. And then now we're able to add in vaccine information as well. So today's takeaways, this is really urgent. As we saw, the deadlines are coming up really, really fast. And that data exchange work group is really the place to engage, or at least to listen into, because that's where all of the conversation is really taking place. Today, we're going to hear a little bit from stakeholders about challenges and opportunities. So at this point, I am going to stop sharing my screen, and I'm going to introduce you to all of our speakers today. So our speakers today, we have Dr. Stanley Frencher, who's an associate professor at the UCLA Urology, medical director of surgical quality outcomes at Martin Luther King Jr. Community Hospital. We have Dr. Michael Fu, who is the national director of behavioral health at Hazel Health, Inc. We have Erin Jackson Ward, who is the director of community benefit giving space at Cedars-Sinai Hospital. And we have Mohit Ghosh, senior director of government relations at Anthem, Inc. So with that, please go ahead and turn on your cameras. I think we've got everyone here. Thank you all. For our first question, I would love to have you all introduce yourselves a little bit beyond just the title that I used, and then explain why health information exchange is really key to your organization's mission and success. Maybe we could, I'm just going to go around my screen here. Maybe we can start with Michael. Please go ahead.
All right, thank you, Katie. Really glad to be able to be here today. So my name is Michael Fu. I am the National Director of Behavioral Health at Hazel. Just real quick, and I'll talk about this in other questions. I've had the privilege of serving students and young people in many different capacities in different environments, from school settings. I used to be a middle school teacher, in the clinical setting, whether in the hospital or in FQHCs or juvenile justice centers. And one common theme, even outside of my job today, is it's just really hard to understand what's going on in a student's life beyond that moment that you see them. And so what we do now is deliver both comprehensive physical health and mental health services to students through their school systems. And I can talk more about why that's valuable. But as you can imagine, we're talking about healthcare exchange for health systems. The school is not even part of that, but there's so much potential. And when you see somebody at a site like a school, you have such tremendous opportunity to inform others, to understand what is going on in that student's life, to create treatment plans or care plans, or to continue them. And so for us, unfortunately, there are barriers to that. We don't have a lot of information. Think of us as urgent care, your emergency service sometimes in a school. And when you're flying a little blind, it's really hard to figure out what's the best way to approach. So I'll pause there, but there's definitely value in looking at the school as a use case for why this definitely matters.
Yeah, Michael, thank you. And I know we'll get into a little bit more sort of how you do that, thinking about the school site and sharing information out and taking information in. Thank you. Let's go with Stan.
Thanks for having me, Katie. And yeah, for me, it comes down to two kind of hats that I wear routinely. And I think the first is I'm a urologist practicing in the safety net, I practice in South Los Angeles, and part of the need for improvement in health information exchanges is what I see every day when I see a patient show up to the emergency room whom I've performed a procedure on. But the emergency room doctor has no idea what I did for that patient because they don't have the information readily available at their fingertips. And so as a provider, it's really important, as a clinician, for us to think not just of what's in the health information exchanges, but also how that's delivered at the point of care for us, so that it's something that appears to be useful and helpful when delivering care to the patient, like in that moment. When we see patients on the ambulatory side, understanding what happened at their hospitalization, is more than just the passage of records, but really determines whether or not that's going to be a valuable visit when they see me in the clinic. So I think that's one perspective that I bring. The other is, in the work that we do, as part of expanding access to virtual specialists, here in the Inland Empire and throughout the state of California, working with the Department of Corrections and Rehabilitation. I'm the CEO of HubMD, which is a program where we expand e-consult, which are conversations between specialists and primary care providers, asynchronously. we find that that may sometimes be the only way that primary care physicians understand what's happening to their patients outside of their immediate visit, when they're communicating directly with the physician, and the lack of ability to exchange information across correctional health facilities and county facilities and into FQHCs and primary care practices, it really hampers our ability to care for patients longitudinally. And so I think I bring both of those perspectives and look forward to the discussion about use cases, particularly as it pertains to improving the care of our justice involved patients.
Thank you, Stan. I also appreciate that you mentioned taking care of your patients longitudinally, so over time. And there is a piece that I didn't put on my slide, but for those of you who are really into the data, there's also a requirement to start thinking about a master patient index. So that would allow you to look at that information over time and across different providers and plans. Thanks for that. Erin, please go ahead.
Hello, everyone. Thanks for having me. I'm Erin Jackson Ward, and as Katie shared, I'm the director of what we call the Community Benefit Giving Office at Cedars-Sinai. I oversee an office that has the privilege of acting as a grant maker. And so we give funds to organizations, nonprofits in the local community that serve vulnerable populations very heavily and deeply in the access to care and social determinants of health space. And so while I certainly hold the perspective of Cedars-Sinai as an organization and health system, my lens for purposes of this conversation are informed by my community benefit hat and specifically from a funder's perspective. And a lot of what I understand is from feedback directly from our grantees and the community-based organizations themselves. And we're trying to build the capacity of a lot of organizations, focusing a lot of our efforts on investing deeply in integration and kind of the continuum of care. And when we're pushing that, we're running into a lot of barriers when it comes to data sharing. And more personally, my background's in public health. I've worked with pediatric HIV populations, formerly incarcerated folks, people experiencing homelessness, and no matter which space I was in when I was working, it was always an issue for all of the reasons shared thus far. So I'm really excited to dig into it a little more.
Thank you. Excited to have you here. And, I appreciate hearing you talk about community-based organizations and social determinants of health, because I know that they've been a huge part of the COVID response, and also I think where we're going in CalAIM and other Medi-Cal initiatives, specifically to serve vulnerable populations. So thanks for bringing that into the conversation. And last but not least, Mohit, please go ahead.
Thank you. And thank you to the team, both at the coalition and for you, Katie, for the work you've already started doing in this space that I think will be meaningful to this advisory group that HHS is currently running, because as you pointed out, we're already in a sprint. So, as a digital first company, Anthem's interest in data interchange is, kind of our first thing, right? We want to be able to meet our patients where they want to be met. We want to meet the provider community and address the needs on that front. We really want to be able to create a system where there's actionable information at the point of service, right? We find that if you have the right information and you have the right evidence base to work from, then the care being provided at every level within the system hopefully will get better. And when you look at this through the lens of access, equity, cultural competency, all of those things come into play. But in order to make it work, you actually need to have the data at your fingertips. So from our perspective, and Michael's point is not lost, there's a lot of change happening across the healthcare system in California right now. A large degree thanks to the budget largesse that we've experienced. It's great to be in a state that has budget surpluses, but our interest in this is to work with all of the stakeholders, including all of you on this call, and of course the state itself, to ensure that the monies being spent are being spent to build long-term sustainable infrastructure, right? And that's our focus, because we understand that if we need the data to flow openly, there's many different barriers that exist today. And the extent to which we can all come to a common agreement on the use cases, on the appropriateness of data sharing, on the providers who need to interchange data in a bidirectional way in the course of treatment, all of those items are things that we hope that this work group that is currently empowered by AB 133 will be able to address and ultimately create a better infrastructure for health information exchange.
Thank you, Mohit. So what I'd love to do next is talk about, have each of you share your top use case. If you could share data today, what would that top use case be that you think the advisory group should consider really doing first? And then after that, I'd love to hear, we're going to go around again and talk about what you think they need to do to make that happen. But I wanted to start with the exciting part first, is what can we do with data exchange in your ideal world? So I'm going to go back around the other way. Mohit, why don't you go ahead? Oh, I think you might be on mute.
I am on mute, sorry. So let me jump right in. I think I'm going to speak to it from a lens of behavioral health for a second. I think one of the issues that we face across the state is the lack of being able to follow the patient, especially when, at least in the Medi-Cal system, and I know you recognize this, Katie, very well, that the Medi-Cal system for behavioral health in California is bifurcated. So and this isn't, this is a use case, but it's something to consider. The information lives either within counties or within health plans or within both, but it's different sets of information. And in order to seamlessly allow the service model to follow the patient, you really need a better level of interconnectivity. And this goes to one of the issues that you raised earlier, which is federal versus state versus county legal teams all having to be in the same room in order to solve for that exchange of data. I think unfortunately, the issues around liability for data leaks or issues around liability of sharing highly sensitive SUD and other information come into play here. And so it's not something you can blame people for being very careful about, but at the same time, with the technological advances that we've made over the last couple of decades, I'm still fervently hoping that at some point that data, which is highly protected, can flow seamlessly between and amongst providers, payers, government, and others who need to not only curate that data, but then get it to that point of service to be actionable. So I would say BH is a major area. And I didn't want to steal anything from Michael, but it's just something that's been around for a while that I've been focused on in 8 years of doing some policy work here in California.
Yeah, thanks, Mohit. I think pre-COVID, we were talking a lot about behavioral health integration. I know that working in the county behavioral health system is a huge initiative under CalAIM, so very timely, as well as youth behavioral health. And that big state initiative. So, you're right, behavioral health is front and center, not to mention, I think just behavioral health needs of everyone who's, been impacted by the pandemic, students, and even providers who are delivering those services and are also experiencing burnout. So I'd say behavioral health is right up there. And I also wanted to pull out that challenge that you talked about, is really getting everyone on the same page. Not only, saying, yes, we can share data, but actually getting the spirit of that right to actually sharing data. Because I think folks will come in and say, yeah, sure, we can share data. But then when you get down, as you said, when you get down to the nitty gritty of it and you get folks in the room saying, well, actually, we're not sure we can share that. I appreciate you pulling out that we now have the technology to provide highly secure data feeds to people. So I think that, when you looked at that timeline in my presentation a little bit earlier, I think that is a major difference between now and really sort of the mid 2000s, the last time the state was talking about that. So thank you. Erin, please go ahead. With all your experience, what's top of mind when you think about what we can do with data exchange?
Thank you. So I'm going to go a little bit broader and talk about CalAIM. When it comes to CalAIM, there are 3 primary goals, and I'm sure I'm not the biggest CalAIM expert on the call, so please chime in to correct me if I misspeak. But essentially, the goals are to identify and manage care and risk through the lens of social determinants of health. It's a theme for me today, as you will notice, essentially informed by the whole person care efforts over the last few years. That's number 1. Number two is reducing the coordination complexities that are historically inherent for Medi-Cal members. And number three is ultimately reducing health disparities through these types of value-based care initiatives. And so, in my opinion, these can't really be achieved without the data sharing piece. So, for example, in order to address the social determinants of health of members, a lot of different systems are involved, kind of like what I was saying in my introduction, where everything from food services to housing to medical and mental health care, behavioral health, like we were just talking about, are all on different systems. And so in order to achieve that first aim of CalAIM, I think that data sharing is critical. And then to that second point of reducing coordination complexities, even if partnerships are formally established, the data piece will be a barrier to that coordination if the infrastructure isn't there for it to be easily shared. So I would say, yeah, that's what comes to mind when I think about where we can go and what excites me about the prospect.
Absolutely, thank you. And again, thank you for continuing to keep social determinants of health. I think, as Mohit talked about, behavioral health really is the intersection of at least two delivery systems. There's so much more out there that plugs into the delivery system. And you said particularly for vulnerable and complex cases, this really does span the whole health and human services spectrum. So to really get a whole person focus, which is really what CalAIM is trying to do, we need all of that together. Thanks. Stan.
So I mean, I'll probably come at it from the lens of the work that I do currently with correctional health, and on the the Medi-Cal space, because I think that it fascinates me when I as a specialist working in the county systems in Los Angeles, and as provider of telemedicine for correctional health facilities statewide, the challenges we find in the sharing of data across those two public entities, right? I mean, both publicly funded, both caring for essentially the same population, the same challenges from a social determinants of health perspective are those found in our populations who are largely served through Medi-Cal, as are the patient population that we find in state prison systems. Coincidentally, they also share many of the same challenges and disparities and inequities as it pertains to chronic disease and to chronic disease management. And I think two things come to mind. I think one is the prospect of health information exchange improving the care of patients as they migrate between the two. So most of our folks who are justice involved will be back into our communities, many of whom will struggle to find employment, struggle to migrate up the income scale such that they will be eligible more than likely for Medi-Cal when they arrive, and most likely seek care in some of our publicly financed agencies. And secondly, the providers who provide that care need to be able to have actionable data in both settings, and neither of those things happen currently. And I think we have to, and I'll put my specialist hat on, so much of the need for us to care effectively for patients depends on all the data that's been obtained prior to us seeing the patient. Otherwise, that care becomes redundant, duplicative, and typically wasteful. And so the exchange of information both helps in terms of at the point of care delivery when it comes from the provider side, and for that patient to feel confident that when they go from one setting to another, that they'll be able to receive high quality care. And the interesting piece is, at least in correctional health and from a county perspective, they already work together. We're already talking about institutions that essentially are taking care of the same patient population as they know they are, just there are barriers to exchanging the information effectively. So I think that's a great use case for putting the resources in a place where already you have, I'm sure, stakeholder buy-in at the care delivery level. We just have to work on those upstream challenges that have already been kind of outlined to ensure that information can be exchanged effectively.
Yeah, thank you so much. One, for bringing in the reentry and justice involved population. That's actually a key focus of CalAIM, but I think one that we don't bring up very often. So thank you so much for sharing that. And I appreciated that you talked about buy-in already at the provider level. Trust is such a big part of sharing this data. I think to Mohit's earlier point, If you trust someone, it's going to be easier to get beyond sort of those legal, gray areas and hangups, and really share, information for the right reasons. So thanks for bringing that one up. And Michael, please go ahead.
Sure, Mohit set me up really well. I think I will also take it from maybe an advocacy and population health perspective. So I think a lot about patient experiences, and I know we talk about how it can reduce duplication in systems, but when you're talking about behavioral health or mental health in general, where a process of talking about traumas and revealing vulnerabilities, data exchange helps put patients ideally in a position where they don't have to relive and keep doing that part of the process over and over again. So that's just one more experiential component of it. But I think that long-term data exchange can be used at an advocacy population health level. So how can we actually aggregate this data and use this data to specifically identify gaps that exist within locations and share that information across systems? And the reality is we all operate in silos where we have incomplete data. This might be able to help us evaluate things like ROI evaluations, impact evaluations faster than what we're able to do now. And so that crosstalk can be used to advocate for certain populations. And I think right now we see blind spots that we can't uncover because of the limitations of data and what people are doing in other different parts of the health system. The other thing is just around, I think, as we move to more giving patients control of their data themselves. I'm an immigrant, my parents are immigrants. They're very scared of the medical system. And so giving them power and control eventually over their records is really great. But until we get there, how do we as a system see enough information about a patient to all advocate for them at that point in time? Meaning like, hey, actually, this is not the diagnosis that you actually had that you're telling me. What actually happened to you was this based on the records, and just having alignment there. I think that provides another way for us to say, as a system, we're supporting you in that journey to basically have more control and understanding of your own medical data before we actually put it directly in their hands. So two other perspectives on that.
Yeah, Michael, thank you for really bringing it back down to the individual who's engaging with the health system. Really appreciate that. So how are we going to do this? All these great things that we can do, in the short amount of time that this work group has to consider and really come up with this framework. Do you have any advice for them? Like, what are the key things that you think are going to make sharing data real time? What do you think really if you could pick an element that had to be included in the framework, what would it do? And I'm going to just popcorn around my screen here at this time. So maybe we'll start with Erin.
Okay. So I've thought a lot about this. And I think that kind of the theme that you've been seeing is maybe starting with one area to make it tangible and expand from there. So there's a lot, and a lot of times this can feel overwhelming because it's a huge issue that we're trying to tackle, and we feel tight with a lot of the timeline and that we're trying to kind of catch up. So, but there's an opportunity to take a step back, find a lane, and then go deep, and then develop a playbook for how it's done before expanding and kind of going more broad. And it could be immunizations, it could be emergency room admissions or schools or wherever. Any of those would be a fine start. It doesn't make as much sense to do it kind of plan by plan. And ultimately, you can then make sure to engage all types of organizations in that one particular lane, including non-healthcare organizations, back to the CBOs that we were talking about, and then crystallize that kind of every provider on record has real-time data for their patient when they're admitted to a hospital, for example, or things like that. So I would say start somewhere and then expand and adapt and share the lessons learned as we continue to grow.
Thanks, Erin. I love the idea of a playbook. That sounds like a great idea. Let's see. Let's go to Mohit. Go ahead.
So I think there's going to have to be a carrot and stick approach here, right? For whatever reasons, we've had some intransigence in data sharing, and I'm not making light of any of the reasoning out there. But equally important is the ability to do what we're all talking about, right? Whether it's with justice involved, whether it's with students, whether it's with SDOH, what have you. But I also very much agree with where Erin was, which is that let's not try to do everything tomorrow morning. And the reason I say that is because you've got to define a system that actually works before you start adding to it, right? So there are, for example, there's I think 6 or 7 established HIEs across California right now. And you might know Anthem is a part of Manifest Medics, which is run by Claudia Williams, who happens to be on the advisory group for DHS. The reason I bring that up is that, as we build this out, HIEs have been building and doing these things for several years. They've established the protocols. They've understood the needs for security. They've built essentially a system that could be part of that maybe slightly more decentralized system that was on one of your slides, Katie, that you brought up earlier. So maybe there's a pathway that those providers, plans, others who are in those HIEs could be deemed to be compliant with 133, the extent to which it can all get aligned the right way. And those who aren't have the option of either joining one of those HIEs or coming into compliance in some other way. Now, it's not to push anybody to join anything in particular. It's just to, jumpstart getting that 130, the goal of 133 accomplished in a shorter period of time. And then the other piece here is that the data needs cleaning. And there's got to be some kind of way, either centralized or decentralized, where that the data can be cleaned, scrubbed, and matched. And the reason for that is that we see this all the time. I mean, even self-entered data, if you have the wrong address in there, it doesn't match you the right way. And then even if you are an Anthem member, we don't know that you're the same person. You could end up being in our record twice. So cleaning of the data is also equally important as we build out the broader exchange of data. So those are the things that I would think through as base level infrastructure before we start. And I'm not taking away from SDOH or any of those things, but I think it's important to understand that some of these providers that are now going to become part of the fabric through the SDOH work that we're doing in CalAIM, some of them have never billed, some of them have never dealt with a code, some of them don't. So there's a whole aspect of practice transformation and education that needs to occur prior to even having data coming in the right way from those entities. So take it in, let's build the core and then start adding to it as more providers or more ancillary providers or CBOs even are, get more familiar with the data exchange concept.
Mohit, thank you so much. I mean, there's sort of this broad idea of all the things we can do with data exchange. And then as you and Aaron have said, it really comes down to this granular, how do we actually share one piece of data and what is that piece of data? So there's a lot in between those two. And I'm hearing a theme here, let's do this methodically. There was a question that came in from the audience. How have other states done this successfully and can we learn? My presentation just a little bit earlier, I mentioned Michigan and Washington, D.C. I know we've also heard it sort of out there. I know the organizers of this have also had Colorado speak to a smaller group of people as well. So yeah, there are a lot of examples, in successful health information exchanges out there. You can see some of those in the ITAP policy forum link that I dropped here. Take a quick look at the slides. It's really easy to flip through them, I promise. And then I also dropped a link to the California Healthcare Foundation's data exchange collection. There's a lot of deep information in there, but some of those actually talk about some examples from other states as well. So a few more resources for you all. And I'm sure Robbie and Timmy will also put some stuff in the chat for you as well. Thank you.
But
and then
Katie, before we jump away,
Mm-hmm.
That's a really important point because, interoperability and data exchange has to also happen across state lines. So we can't forget that. And that, to me, there are some, federal regulations in that space, but there's also non-regulatory work that's being done. Things like, that are being set up. I think the acronym is TEFCA, that, that is a voluntary system. But again, being able to share that data appropriately across the entire country, it becomes equally important, even as you get to the localized way of delivering care. So I didn't want to lose that because states and across state lines also matter.
Yeah, thank you for underscoring that. And there, we talked about it a little bit earlier, but there's a nod to that in the language in AB 133, which is leveraging those national standards. And as you said, Mohit, there's other work going on as well, which is really important. All right, let's go to Michael.
I would just really piggyback off everything Aaron and Mohit have already said. I think historically, New York, for instance, has had some success as a state with their regional HIEs. And it seems like high level, some of those models that have worked, again, have kept it simple, have prioritized those tangible use cases, whether it's, for instance, like simply sharing, consistent way of sharing lab results, right? And things like that. And the key is grounding it to, you want to hit this grand vision of all this data that you can exchange, but it has to be contextualized and relevant to the communities that you're serving. And so with the practice transformation, these have to be pieces of data that are valuable and vital to the daily activity for a healthcare provider. And so on top of that, I think it speaks to not overlooking the power of even simple data, right? Like ADT data, like emissions and things like that. We don't even know that at some levels of care. And so there's easy wins that have a big impact there as well. If we can have success early on, that will set the stage for these larger visions that we have as well. So definitely just agree with what Mohit and Aaron have said.
Now I'm muted. Great, thank you, Michael. You're right. Making sure that they have someone on the work group who can get into those technical aspects, even to make sure we can share the simplest data is really, really important. There's also another Q&A question that came in from the audience. How do we ensure uniformity on collecting and reporting disaggregated race and ethnicity data, particularly within the AAPI community? Really great question. And Robbie, I know you dropped in a couple resources into the chat, so please take a look at that, folks. But I think it just speaks again to what Michael's talking about, or what Mohit was talking about. The cleaning of that data and the records matching is just so critical and is a big piece of the exchange of data. So thanks for that. All right, Stan, take us home. What are your recommendations for the work group?
Yeah, I mean, I'll kind of keep it simple. I think healthcare is still local. And I think that, we talked a little bit about focusing on different use cases and different settings. I personally think like the success of regionalizing some of the approaches and digging deep in one particular area with a select group of providers across the full continuum is probably a way to build that playbook that Aaron was talking about. I think that most patients do not extend to receive care outside of their local environment. I think that most of folks who are accessing resources to address their needs from a social determinant of health perspective are getting those needs locally. Often transportation is one of those big ones. And so I think that thinking through how we dig deep in a particular area, build it out and expand it, either through your hub approach or through other ways to create that, those connectivities across regionalized settings, is a way to deal with the real challenge of making sure that the data is actionable to the local providers, right? Because you need their detailed involvement and consistent involvement to make sure that you're getting feedback. Because the biggest feedback I get from clinicians is it's just not helpful. Like the data that I'm getting currently through many of the established HIEs just aren't helpful. Like it's not real time enough, or it's not easily accessible enough. So I think digging deep in one specific locale, particularly for California. I mean, I think some of us forget how big California is. And I mean, it's bigger than many countries in terms of its economic, financial, largesse, but also in terms of its geographic vastness. And so I think that thinking through how we can dig deep in certain areas and bring on the larger stakeholders in those communities would be my biggest advice. And then connecting those areas across a unified playbook like that, Aaron.
Yeah, Stan, thanks so much. I appreciate that. Healthcare is local, right? We're talking about each providers providing care to each individual. Do any of you have recommendations? I'll just open this up for the group on how folks can engage at a local level. Mohit, you talked about how we have regional HIEs, we have this work group. We've got a great audience on here. Do you have any advice for folks on how they can engage at that local level, or if they are bringing people to the table, who should they bring to the table? Should that be the role of the state to have regional working groups? Are there regional working groups already going on this topic that folks should plug into that you're all aware of? I'll just open it up to the group.
Well, I'll use an example that Michael, I think, will be pretty close to here. You know, one of the biggest things we've embarked on in the Medi-Cal system, even outside of Cal-AIM, is this massive build out of behavioral health care for children 0 to age 25, right? The entire young adolescent and young adult population as well. And a critical piece of that is being able to not only allow the programs to follow the person, but equally importantly, have that actionable data at the point of service. Whether that's inside the school or whether that's after identification and screening at the school level, where does that patient go next, right? Or where does that member, in my case for Anthem, go next? And then how do you build out that not only the ability to follow that patient and follow that member, but to make sure that the right amount of data is getting to each point of service. So to me, that in a microcosm, because we are devoting, $4.5 billion in California towards the building out of BH infrastructure, that would be a very interesting use case, even as we work on Cal-AIM. The point that Aaron made earlier is not lost on me, that there's a lot of work that's happening on that site as well. And, for us at Anthem, we're in 29 counties for Medi-Cal. We're doing maybe 75 meetings a month right now to stand up Cal-AIM. So there's a lot of work happening there, but equally important is the Student Behavioral Health Initiative, because that fits into the broader, how do you make sure that that BH data is curated appropriately, but actually goes with the patient in order to deliver the right service, whether that's telehealth or anything else.
Yeah. So what is, Mohit, I appreciate that you just brought together two state initiatives that involve a lot of local work and a lot of state work. So what is the role of the state in sort of leadership and governance and tying all these together with HIE from sort of that leadership and oversight perspective?
It's the role of government. It's to set the rules of the road, right? I mean, set the rules, make sure people understand what those rules are, and then encourage the innovation that the private sector brings to the table in order for the connectivity to flourish, right? I mean, I find that there's equal parts of, if the rules of the road are clear, people agree on the generalities of, this is what you must have. This is the level of security. This is the level of interchange. These are the fields, depending on the use case, because you always want to be compliant with HIPAA, only sharing that amount of data that is necessary for the point of service. So that, I mean, I would say, let's get the rules right. Let's invest in the infrastructure to enforce those rules and then push it out into the communities that are already building HIEs.
Yeah, a lot of this work's already being done. Thank you. Aaron, from your perspective with your grantees, so those are the community-based organizations, sort of the corollary to what Mohit's talking about. What do they need from the state and from a leadership and oversight perspective to be successful?
Yeah, I think that there's an equity piece that we haven't explicitly acknowledged yet. I mentioned health disparities and stuff like that, but and Michael even alluded to this, right? Where there's this priority, I think, that in trusting the system, right? There's a lot of historic reasons why folks don't, and I think that listening to the people on the ground doing the work is a critical piece of this. We conceptually can all understand it sitting in our various offices, and I think that listening to the people on the ground, understanding what the barriers are that they're facing, both tactically, but then also philosophically and emotionally, all of the things. I think hearing the folks throughout the system in order to inform the decisions and being responsive and intentional with how we're building it out.
Thanks so much, Aaron. Stan, going to you as a provider on the ground, being frustrated by these missed connections and the need for more data. How can the state help lead when healthcare is local? Is it funding? Is it rules, as Mohit was talking about?
Yeah, I'm a big fan, given my entrepreneurial hat, of public-private partnerships, right? I think that ultimately the innovation occurs when folks feel like they can create a business model, and they feel like they can create a business model when they know the rules of the road, and then they know that that it's a competitive landscape, that they understand like the challenges and the problem they're trying to solve. And I think that the role of government in that setting is to Mohit's point, setting the rules of the road, not just for partners to participate in HIE, but to allow innovative entrepreneurial types to come into the space and to really create a sustainable business model around exchanging data. I think short of that, like, I don't think you get the accelerated change that you need, like, in this space. And so in that sense, the role of government is in part funding, but is in part providing those rules of the road, and then allowing space and opportunity for innovative entrepreneurial types to come into that space and then create the true user interfaces and exchanges that folks on the ground, both from a CBO perspective and clinician perspective, can use well in their individual settings.
Really appreciate it. So speaking of ROI and innovative products, Michael, please go ahead and I feel like you have something to say on this. So please, you as an innovator, what do you need from Sandy really sets this up nicely for him. What do you need from the state to be successful?
Honestly, I think we've seen this with, I mean, if you worked in mental health, specifically children's mental health for any time part of the past decade or so, you've never seen a time like this right now, where there's political will, not only in California, but across the country. There's massive investment in the private sector. People are finally paying attention to this. And I think as a state, that is one of the biggest things you can influence. Basically, it's the carrots and the sticks. Do you create enough incentives for somebody or pressures for somebody like a Medicaid system or the health plan system to say, hey, we're actually going to devote funding and attention and time to make this happen, right? And so what we see as innovators is this type of approach, these policy pushes, these budgets have really motivated the big players that hold power to say, hey, we're going to invest in innovations, young, new, as well as, old ones, to actually deliver on these services. We are still at a point where not everybody knows how to do it, right? Like the idea of doing things like enhanced behavioral health care data exchange, they're really great. But now we got to dig down into the implementation level. And as we surface those additional barriers or challenges, I think those best practices need to be come out and need to be listened to by the state to say, if we actually want to commit billions of dollars to this and make an outcome happen, we're going to have to keep adapting this plan as we deliver it. So not sure if you want me to go into the school-based just perspective, but right now, but I do think it comes down to carrots and sticks and how do we keep driving that forward, even after the initial policy passes.
Yeah, Michael, thank you. I think the next conversation is going deeper on school-based health. I think that would be a fantastic follow-up for him if I can put that out there. Thank you so much. Huge thank you to our speakers. It's really been great listening to each of you. I feel like I've learned a lot. I know our audience has as well. And with that, I'm going to turn it back to our host, Timmy.
Thank you. Thank you all. Thank you, Katie, for such a great, rich session. And it was just, so timely to be able to entertain the, this kind of visionary, yet bring it back to vision, but then bring it back to reality. I think for all of us, we know that the urgency is there, but that we have examples from other states. We know that it will take months if we put our mind to it and our resources to it, not years. And then also just for what my big takeaway was, start small, start incremental. If we can start, just in general, start and then solve and scale. If we use that as our motto, I think we're going to go really far. And then finally, I really would offer for us to continue this discussion. I know Katie with ITEP will be looking for your programming throughout the year. The Connecting for Better Health, we meet on a regular basis every other week. We would welcome all of you to, if you're interested, in join that discussion as we track progress with the state, and then also learn on how we can be successful on day to day as well with the work that we do. So thank you all, and have a great Friday. Take care.